In Health Coaching and Beyond, Tim and I aim to mix up conversations between the two of us, chewing over hot topics, latest news, and emerging ideas, but also bringing you conversations with thought leaders and people we admire in the field of health coaching and beyond. People we hope will help you think well and spark interesting ideas for yourself. This week, Tim and I talk about a really interesting, perhaps slightly controversial, rapidly emerging field, mind-body medicine. Whilst considering how mind and body interact may seem as ancient as medical wisdom itself, it seems to have got lost in modern science. We explore how new discoveries in psychology, neurology and immunology are helping us to understand what is happening at the chemical level and renewing the focus on how we diagnose things like neuroplastic pain and restore our understanding in areas we've traditionally called medically unexplainable symptoms. Most excitingly, we explore how this new understanding is leading to new, more effective treatments. We draw on our own clinical experience and a rapidly growing body of knowledge and experience amongst trusted medical colleagues. We're all experiencing the joy of having something to offer instead of, sorry, you'll just have to learn to live with it. We hope you enjoy our banter and it sparks interesting thoughts and ideas for you, whatever your role.
Hi, Ollie. How are you?
Very good, Tim. Nice to see you again. As
Yeah.
usual, you're more smartly dressed than me. I'm a bit casual, but that's
Good. I'm glad we've resorted to type. I think it's about time, to be honest. Yeah, and it's us talking today. I mean, I love the conversation, the heart to heart that you had with Caroline. I thought that was such a good episode, and I encourage people, if you've not heard that one, then definitely go back and have a listen. But yes, it's us today having a
does.
conversation.
Well, that was a great episode, wasn't it? It proved beyond doubt who is the most intellectual heart in the Hart household. Anyway, at least I can say that, can't I? And I know it's not me.
Yeah, and maybe the most intellectual and accomplished director, maybe, of peak health coaching. I think we
Afraid
could
to
say
say, we're going to have to admit that, aren't we? So you've got the two, the two simpletons today just chatting away, yeah?
Exactly. So you have been busy. I know I've seen some posts on LinkedIn, and I think you've had a weekend with some folks looking at mind-body medicine. It sounds like a really great weekend that you got. So I'd love to hear a bit more about that.
Yeah, it was really interesting, and I think it is a hot topic, isn't it? Because I think it's an area that is growing really quickly. I mean, we see loads of our colleagues, don't we, in general practice, very interested in this. But we also see a bit of kickback, hear people getting criticised for approaching this, and even the sound of it, isn't it? Mind-body medicine. It sounds a little bit sort of on the edge of what you might consider acceptable mainstream medicine, doesn't it?
Yeah, and I think you said actually in your LinkedIn post about the importance of defining it. And maybe there's people listening who haven't yet come across it. It's possible, haven't yet come across it. So I don't know, where are you up to in terms of defining it?
Defining it, yeah. Oh gosh, mind-body, it's nothing majorly new, is it? It's just recognizing mainstream that what goes on in our minds, our emotions, our feelings, our thoughts are directly related to the symptoms we experience in our body. And I think we've learnt, particularly over the last decade, again, I think really, that so many more of the symptoms that we might have traditionally said are medically unexplained. We might come back to that, isn't it? It's an area that our friend Professor Chris Burton has been addressing in his Lancet study. But this concept that, some things are just unexplainable medically. Actually, we're realizing that they are explainable when you connect together our emotions and our thoughts. And it's opening up new treatment pathways, really. But it's important to realize, I think, so it's mind to body, but also back the other way, body to mind, how much our kind of somatic feelings also affect the way we think. So I suppose it's a recharging of the direct connection. We shouldn't be separating the mind and body. The two are intimately connected.
And do you think that's what's happened then, Ollie, I suppose, in terms of our training, in terms of, or maybe all Western kind of physicians have been trained in this way now, that we have kind of separated these things out? And maybe, people have got ultra kind of specialized in one particular area, but we're missing the kind of the bit that connects it all up. What do you think?
Yeah, I think so. I mean, even just the division, between mental health and physical health, obviously it makes it easier for us to sort of like conceptualize which is the main thing that's going wrong, but you can't divide the two. When you've got sort of some of the clinical diagnosis of mental health problems, anxiety, depression, you are going to have physical symptoms related to that. We know that. And I think we're just deepening our understanding that actually that extends into other areas where we didn't really take it into account. So particularly, the areas that we've had a lot to do with chronic pain, haven't we? We've seen in chronic or persistent pain, the role of emotions and thoughts and feelings have become much more crucial, as demonstrated on functional MRI scans. And, it's really well proven. But I think we're seeing that also extend into, areas like, irritable bowel, functional neurological disorders, there's a name for it, chronic fatigue. You don't want to exclude some physical sort of physiological things that you want to notice and make sure are not happening. But actually, mainstream medicine needs to look for both the kind of physiological stuff, but also the emotional and the thought-driven stuff as well.
Yeah, and I know, having been on a course with Howard Schubiner, who's talked a lot about kind of freedom from chronic pain. Certainly, he's very keen, and it's really important that we rule out that the tissue damage. That we rule out those things, those physical causes, before we then say, "Oh, could this be a mind-body condition?" So making sure we're ruling out cancer and infection and trauma, inflammation. We need to rule those things out before we then rule in a mind-body condition.
Yeah. So Howard Schubin has been one of the leaders in this area, isn't he? And I know he coins the term with Dave Clark, who's set up the Association for the Treatment of Neuroplastic Symptoms, ATNS. And I think this, if you want to put a posh word to it, isn't it? It's that, we have neuroplastic, so conditions that have been generated through the neurology, the way we think, the way that then gets converted through the nerves into sort of hormonal and neurological pathways in our body. There's even a phrase for it now, isn't there? Psychoneuroimmunology. There's a whole area of expertise. But Howard was one of the main architects of that, wasn't he? But like you say, he's been really careful, isn't he, to make sure this is a fully integrated approach. So you're doing your due diligence as a doctor to exclude other, perhaps more physiological conditions where there's a different treatment, but nevertheless now we can make a positive diagnosis of neuroplastic conditions, and then it opens up a new treatment pathway.
Yeah, and I think that's really exciting, isn't it? That actually there is something therefore that we can contribute. So it's not just something that we have to go and see someone else for. I think it's important to go and see people who can support us in this way. It's not something we have to do by ourselves, but we can absolutely collaborate and contribute, which is maybe not something that maybe we've been used to doing for our own health.
No, well, and it's certainly really exciting in the pain clinics, isn't it? I mean, I'm involved in a community pain clinic myself, and I've seen so many other sites jumping up, building on the back of, the most advanced pain management programs and so on, where, it's this positive diagnosis that your symptoms are predominantly neuroplastic. So they're driven by your thoughts and emotions and feelings more than, lasting ongoing damage in your body, the traditional sort of physiological damage or biological damage that we would expect. But it's more being driven through a pathway of those emotions and feelings being converted into symptoms. It opens up a whole new treatment strategy, doesn't it? Which is really exciting, because I think we're seeing those treatments work, aren't we?
Yeah. So what was the feeling then? You went away for this weekend. What was the feeling that you came away with from that?
Well, it was really interesting. I had the feeling that they were some very thoughtful, sort of critical thinkers. They don't want to just be duped by the emperor's new clothes. They're not sort of they are really careful clinicians and scientists. But nevertheless, the commonality was that everyone had discovered or had come to the realization through their career. Because I think a lot of the people there were reasonably mature doctors. They'd come on a journey through, going to medical school, learning all the kind of science and the physiology and the pharmacology, prescribing a lot of medicines, working as doctors in a number of fields. There was A&E specialists, there was neurologists, GPs, there were some physiotherapists, some psychotherapists, all experienced practitioners. And the real thing that bonded us was that we'd come on this journey of realizing that we should be more mindful of the mind-body connection and that we should consider a wider scope of treatments. And I think a universal excitement in seeing how it opens up the potential to treat more people positively and achieve better results. So it was a mixture of shared journey and excitement about the future, I think.
Yeah, and we saw some, some evidence of that, didn't we? In the recent kind of, was it the Channel 4 documentary, wasn't it? Was it on Channel 4?
Yeah, well, yes, it
With
was. Yeah,
Robin Chatterjee.
the one
So
we spoke about a couple of podcasts
yeah,
back. Yeah.
exactly. So that was really, yeah. So again, it's coming to the fore, isn't it? So it's good that hopefully people are aware of it. And again, we'd encourage people to kind of find out a little bit more. But what else would you want to share with people
Well,
about that?
what was interesting from that weekend was there was also a universal sort of slight cautiousness, nervousness, I'd say. Do you know what I mean? I think there's been a few quite high-profile cases of, complaints. People sort of saying this is not true, not proper medicine, you might say. That we might be straying away from the core good medical practice principles. That we might be letting patients down by adopting this approach. And I think there was a universal sort of sense that we must be cautious about it, but also be brave, because whenever you try and push something new, there will always be detractors. There'll always people that want to push back. I know, particularly in the area of chronic fatigue, for instance, I think a lot of patients feel that having a diagnosis where it's been accepted it's a long-term condition and that they need ongoing support. That for someone to come up and just say, no, it's just a neuroplastic thing, it's just all in your head, you've just got to pull yourself together and snap out of it. I can totally see why that's really unhelpful and really threatening. So I think it's reassuring people that this is not to sort of rubbish what's happened, but it opens a new treatment strategy. Might not always be successful, like treatments in any other area, and we may still need to maintain ongoing support and ongoing adaptation for people and acceptance that they may not fully recover, and that's fine. So I think with this field, it's really important to dispel people's worries that we're going to be blaming people, or we're going to be telling people telling them they're making it up, or it's all in your head and it's your fault. I think that's the pushback that I think that people receive.
And I think that's so important, isn't it? That we definitely need to get that message across. That's not what we're saying. We're not saying it's all in your head. We're not saying that you're making it up. The symptoms that people experience are very real, and people need to know that.
Absolutely. I mean, it's just like if you were diagnosed with cancer, isn't it? We wouldn't say, it's your fault. I mean, there are some things that cause cancer, like smoking. You could have a potential to turn around and say, well, it's your fault, but we don't do that. For physical illnesses, we don't blame people. And for good reason. These things unfortunately happen to some and not to others. It's just how life goes, isn't it? We don't judge people. We treat people, but we do try and find the best treatment. And I think that's, for me, why I want to talk about it, why I want to sort of stick up for it to a degree, because I think it's leading us into new treatments that enable people to get better where they couldn't before. But at the same time, we have to hold that it might not work for everybody, and that for sometimes, even if you do have neuroplastic symptoms, we may have to accept it is a long-term condition, and we're helping you to manage it and not fully recover, perhaps, to like some people might be able to, and not be blaming people for that.
Yeah, I think that is really important. It's to hold both of those things. And I think for myself, I've been on a bit of a journey with this, because I remember for most of my general practice, probably going along the line of, with chronic pain specifically, this is a long-term condition, and, my job is here is to help you learn to live with it. And that kind of felt like a movement on from trying to, from people trying to find a cure for it. But actually, it didn't feel that hopeful. And I think for a lot of people, me saying, well, you've got to learn to live with it, is not really what most people wanted to hear, actually. And I think this holds a little bit more hope. It's not saying it's all going to be fine, but I think it's a bit more hopeful than you've got to learn to live with it.
I think so. Hope's really important, isn't it? We don't want blind hope, do you? I mean, hope needs to have a basis for it, doesn't it? And I think what this enables is to hold hope with good evidence.
Yeah. Yeah.
Yeah. I mean, let's circle back to Chris's paper. I mean, Professor Chris Burton, a Sheffield professor. We know him well, don't we? And many of the doctors that took part in his study were friends of ours and based here in Sheffield. So we knew exactly what went on. And it was great, wasn't it? His work on, at the time, what was called medically unexplained symptoms. People coming with what we would probably call now neuroplastic symptoms, and even the title, medically unexplained. In the paper, Chris sort of moved us on, didn't he? He said, "Well, no, these are no longer medically unexplained symptoms. We can explain them. We know what's going on. We can recognise them. We can positively diagnose them." And in that study, when we did that to patients in a gentle and a thoughtful way at their own pace, and help them to reframe and adopt some of the techniques that we can go into in a minute, to address neuroplastic symptoms, people got better. People improved in a way they'd not improved before. So it's just exciting.
So, what do you want to? Should we spend a bit of time thinking about those then? What are the kind of the treatments and those approaches that we've come across that we think might be helpful?
Yeah, and I think this is where perhaps health coaching comes in, isn't it? Because a lot of these techniques, they don't require a huge amount of expertise necessarily. They require some skills and some understanding, but I think that's very teachable to health coaches. And I think what's really exciting is health coaches are starting to adopt these techniques, and because of the nature of the fact that they have time and the basic health coaching skills of making connection and rapport and trust, which underpin all health coaching, set up a great context to be able to address neuroplastic symptoms. So it is particularly relevant to health coaching, isn't it?
Yeah, and I think we just again need to emphasize the fact that what we want is definitely people to remain within their scope of practice. So again, if you're going to be looking at this area, then definitely make sure you get some additional kind of qualifications and proper expertise. But you're right, it's a mindset, I think, and it's a presence that you need, and it's time, and I think that's what health coaches can bring along with their skills.
Yes, absolutely. So let's dive down to the treatments then, Tim. So again, I think they can be relatively hard to explain, but maybe let's have a go between us. So I think that what sits at the heart of it is that emotions and feelings drive your symptoms, and very often that's the strong emotions like fear or not feeling safe that particularly get expressed as symptoms. We see that a lot in chronic pain, don't we? Let's focus there because that's probably one of the most established fields. So it is recognizing that it's the fear, the very understandable fear and nervousness and sort of catastrophic thinking drive the symptoms, and that. First of all, that awareness of that, but then also then looking at ways of reframing it so that you can help people to feel safe enough for the symptoms to dissipate.
Yeah, well, I was just thinking of Howard Schubiner has these six Fs, and now I've said six Fs. I don't know how to remember the six Fs.
Yeah,
That's
so
slight
you've set
error.
yourself up there, haven't you?
As I
Go
said,
on.
I've kind of laid myself up there, but the kind of things that are kind of worse, I think, this is kind of in terms of chronic pain, are the fear of it, which you absolutely quite rightly said. So fear, trying to fight it, being frustrated by it, focusing on it, trying to figure it out and trying to fix it. So those six Fs when we kind of focus on those with some intensity, they kind of almost kind of keep things going in some way. So, and that's a difficult one, isn't it? Because when you have really severe pain, it can be really fear inducing. And sometimes you get really frustrated by it. And again, I've had, clients where that's been the case. They thought they kind of things were a bit better, and then they get a flare up of their pain and they just get really cross and really angry with it. And again, that just kind of perpetuates that cycle. So what they encourage people to do instead, of course, is to be curious about it, which is difficult, I think, when you've got severe pain, but to be curious and observing that pain from a place of safety and, yeah, trying to, I suppose, counter that fearfulness with a feeling of actually you're safe, your body's safe and your brain is safe. And yeah, that's the approach I think they would take.
Yeah, no, and I mean, even describing it, it sounds quite complicated, and it is quite kind of complicated to explain to people, isn't it? But it's kind of helping people to find evidence, isn't it? Like you said, be curious. Can you find evidence that some of your emotions and some of the way you're thinking and feeling could be influencing your symptoms? Some of the best health coaches in this area, I think, are really good at that, aren't they? Helping people to, just self-explore. Are there any times you notice when your pain isn't quite as bad? What's going on there? If there was ongoing damage in your body, why would it vary? When you're perhaps doing things you enjoy or when you're distracted. And similarly, why would it be worse when you're really fearful or nervous or low in mood? Because people often report that their pain goes up and down with these things. I was in clinic the other day and just recently, and it was really interesting when I was trying to explain this to a patient. They absolutely lit up and went, I know exactly what you're talking about. I love feeding the birds. It's when and he showed me pictures. He said, when I'm feeding the birds, I just don't feel any pain. It goes away. It's suspended, and that was enough for him to be curious about, well, how can that be happening? If I had ongoing damage, if there was a really kind of like physical problem underpinning my pain, why would that be happening? And then that's enough just to open that curiosity about new explanation, isn't it?
Exactly. I remember the same thing when I was working at the pain clinic. A chap came and said, actually, when I was watching my granddaughters play football, didn't have pain at all.
Mm.
And again, I was thinking, oh, great, you're using a distraction technique as something that could be something you could use, rather than actually now I'd be thinking, well, that's kind of evidence then of a more of a neuroplastic pain problem. And I remember when I was on the Radio Sheffield, and the chap kind of rang up and he had complex regional pain syndrome, and I was thinking, oh no, don't ask me about the pathophysiology of that. But actually, he was on some medications. He was waiting to see the pain clinic at Northern General, and but he was wanting some advice. So I had kind of coaching kind of hat on, and Paulette turned to me and she said, well, what would you advise this guy? And I said, well, what I want to know is what he's already doing that's working well. And he said, well, what I do is I do knitting. And when I do knitting, what I find is actually I don't really notice the pain so much at all. And again, it's just more evidence of the fact that, with these type of techniques, it's evidence this is a neuroplastic pain contributing anyway. I know there's a bit of potentially some overlap between these different types of pain as well. We need to remember that as well. It's
Yeah,
not just
yeah.
all one and all the other. So yeah, and what was really good about that is, you're not going to get any side effects from knitting, probably, apart from some dodgy scarves and
Dodgy
ill-fitting
jumpers,
jumpers.
for
You won't
Christmas.
get that.
Yeah, so I mean that's the thing, isn't it? Health coaches are actually really well placed, aren't they, to have these more emotionally layered conversations, I guess, isn't it? Getting under the surface with people and finding out what's going on, maybe helping them to understand these difficult concepts. But the other couple of things I was really struck by in the Boulder back pain study, which was, I guess it's always held up, isn't it? It was 2022 it was published now. It's a couple of years back already. But it was where they had really clear evidence that adopting these sort of approaches that we're talking about, what they call pain reprocessing therapy, I think probably quite a lot fits into that bucket, actually. I call it almost pain reprocessing techniques. But they showed an incredible results, basically, didn't they, for people with significant low back pain, with sustained improvement that kicked in after about a month and was sustained at a year, which is kind of really unheard of. But so as well as sort of addressing the fear and the explanation of neuroplasticity, there seemed to be something about an emotional maturity as well, being able to then sort of identify with your emotions in a slightly more, I don't know what they were saying, more like a realistic kind of way, where actually you were able to, express your emotions, to sort of like to accept that your emotions might be contributing in a non-blame, non-judgmental way, but almost kind of revisit why your emotions are built up and allow yourself, to experience those emotions. I think, in fact, you've done a bit of work around that, Tim, haven't you? I think they call it emotional awareness and expression therapy. You've done a lot of
Yeah.
exploring that?
Well, Howard talks about that a lot on his Freedom from Chronic Pain course. And I think it's one of those things that probably you definitely need to get some further training in order to engage in it. And you'd have to be pretty confident as a practitioner to do it. So I would definitely encourage people to get proper training. But I think just an awareness of it. And actually, one of the things that people find most kind of difficult to express is anger. And often when you kind of ask people about their kind of story and they hear about the pain story, you will hear kind of times when actually there were times where they were really kind of angry, but there was kind of suppressed anger was one of those kind of emotions that would be worth giving people the opportunity to express and as a way of managing that. And I thought that was just really interesting because I think, in general practice, the kind of things that have stopped people in their tracks, whether they have a physical or mental health, or as we know, kind of a combination of factors, the thing that tends to stop people improving can be things like that kind of real anger and bitterness about a situation. People in some way just can't get past it.
So what sort of allowing people to experience that, but also, drawing the connection and, not blaming you, not saying it's your fault, but just sort of like helping people to see the value in revisiting that and coming to terms with it, I guess. Is that what you're
Yeah,
saying? Yeah.
exactly, exactly. Yeah,
So, and the other thing that struck me as well about the boulder back pain study, so the sort of the fear explanation and that sort of thinking about your emotions and a better relationship with your emotions, perhaps you could say that's probably a bit clumsy. But the last thing was relationships seemed to be really key as well. There were two relationships they highlighted. There was the trusted relationship with the person you're working with, which again, I think health coaches really build up. They build up that trust and connection by using their health coaching skills to build rapport and understanding and listen. So that trusted relationship with you, with the person you're working with, but then also trusted relationships with other people like you, that sort of peer support community side of thing. They really identified how those things were important. And again, I think that speaks to what we're trying to create with the health coaching field, where people are working either one-to-one or they're setting up things like pain cafes, or they're running groups where there's a real focus on the connection and the camaraderie and the common sense of we're in this together. It has a real therapeutic effect. I think you've almost got to sort of bundle that in together as what are the components of this mind-body approach.
yeah, and I think that the value of groups. I mean, there's lots of values, aren't there? But the one of the values is some of the stuff that we're trying to introduce might feel a little bit left field. And actually, if you've got people in that group who've experienced it and made really good use of it, and people can see how far they've come on, and they're people like them, that's just real encouragement, isn't it, to folks? Whereas us talking about it does not have the same resonance.
Well, there's definitely something about you come back to that hope thing, isn't it? When you see other people who have made progress, perhaps a little bit further down the line from you, that really builds hope, doesn't it? When their story was very similar to yours. But like you say, there's something really authentic, isn't there, about someone who really understands what it's like to live with type 2 diabetes, to live with chronic pain, to have mental health struggles, have that diagnosis of personality disorder. That must be a horrible thing to have, isn't it? But yet, you know, it seems to be that kind of helping people to understand their emotions and work with them, it's really therapeutic. So coming from somebody else who's had that experience and really knows what it's like to have all those labels and all that stigma, I think it's part of the therapeutic healing process, isn't it?
Yeah, yeah, and I suppose the boulder back pain study. I mean, that was very dramatic, wasn't it? I mean, they had quite amazing results. Kind of
They
two
did.
thirds of people being pain free or virtually pain free, and in fact, I think they had to, in some ways, come up with that category because it was a category that had never been used before in studying chronic pain. Was these kind of being pain free or virtually pain free was quite something, and actually, yeah, for two thirds of people. And I think the other thing that they mentioned was that 80% of the people with the chronic back pain, 80% of them, they could diagnose them quite confidently as having neuroplastic pain.
Yeah, yeah. I mean, it's that positive diagnosis, isn't it? Ruling in factors, sort of. I mean, that is one of the things, isn't it, that came out again of how Tuban and Dave Clark's work. What are the features that make you proactively diagnose neuroplastic symptoms? Do you want to speak to a few of those? I mean, I,
Well,
I could bring in
so
Alan Gordon's work as well.
yeah, well, certainly how Tubiner has these fit criteria, which we may have mentioned before, but the F is kind of for functional, stands for functional. So this is kind of symptoms which kind of persist long after the original injury, potentially, or maybe come when there's been no injury at all. That sometimes they're kind of on symmetrical kind of parts of the body, or parts of the body which we don't in some ways kind of connect to each other. We know biologically they don't connect, and yet you're still having symptoms in those areas. So that will be functional. Inconsistent will be the other ones. That's the I. So inconsistent symptoms. So there'll be symptoms that will come on at certain times, and not at other times. So when you're watching your grandchildren play football, it's not there. When you're knitting, it's not there. But other times it comes on, certain times of day, that kind of thing. So um, and then the last one will be if it's triggered by something. So sometimes even the thought of doing something can trigger people's pain. Sometimes, light touch or something on an area triggers people's pain, which, we know it shouldn't be painful to lightly touch an area. So those fit criteria are the kind of the ruling in criteria, if that
Yes.
makes sense.
Yeah, no, I think that's really important, isn't it? Ruling it in, and that was what was so striking about that weekend as well. Actually, one of the things that really stuck with me, there was an A&E consultant there saying that now that he's understood how to rule in neuroplastic symptoms, they recognise sort of 60% of the people turning up in A&E in accident and emergency are turning up with neuroplastic symptoms. So you might think this is a little bit of a marginal on the edge sort of hobby, but actually I think increasingly this is going to have to become a core part of how medicine operates, is that we get good at recognizing neuroplastic symptoms, but of course recognizing non-neuroplastic symptoms as well, when there are other causes that we must treat in other ways. So it's doing both really well, isn't it?
Yeah, it's definitely not just assuming everything's kind of a neuroplastic symptom. It's doing the ruling out first and then the ruling in.
Yeah, and that's the worst thing, isn't it? And I think patients would hate that, wouldn't they? Oh, you just, that'll be that's your fibromyalgia. Yeah, that's your, your migraine's just caused by your worry. Everybody wants to know that we're excluding other causes as well, isn't it? Still doing the blood tests, still doing the really careful examinations. It all needs to go together, doesn't it?
Yeah, yeah, agree. So, is there anything more that we want to share, Ollie?
Well, I think the last thing I think that comes to my mind is just like the last bit of evidence for me that I always think really stands out is that this concept of the placebo effect. And it's always one of those things that when you see a published study, placebo-controlled, double-blind study, we write off the placebo effect. And typically it accounts for about 30%, doesn't it, of the effect. So you can give a tablet and you can compare it with a sugar tablet that has no biological, pharmacological effect. And you would expect that sugar tablet will give a 30% benefit to whatever you're testing. And we're looking for what's on top of that. And I think it's almost like we write it off. But actually what this pulls into kind of plain view really is that there's a huge amount going on with our belief system and our feelings and our emotions that can be manipulated with the sugar tablet that actually we've just written off, So for me, there's something about getting really good at maximizing the placebo effect, because now we recognize it as mind-body. And the flip side of that as well is something we call the nocebo effect. Again, it's equally recognized that if you think something is going to go wrong, you think you're going to get ill, you very often will. Again, I think this kind of is bringing a lot of fields together. I think that's what this is doing.
Agree. And I suppose what really excites me is there's much more opportunity for collaboration between the practitioner and the person who's receiving the care.
Mm.
They have a role to play in terms of engaging it, rather than kind of being passive recipients of care. They are actively engaged, which again I think has been my kind of way of practicing over 20 years of general practice, and it's what's really lovely. It's kind of seeing there's evidence for this way of working, and this is what we should be encouraging, I think.
Yeah, there's real value in people learning skills and becoming good at it, but supporting them in a good way as well, right?
Yeah, exactly.
Yeah. I mean, I don't know if you wanted to touch on the love way before we finish in Basil van der Kolk's book. He talks a lot about internal family systems, isn't he? And I know that's been again another area that's been proposed as a very robust set of techniques that we can bring in here. You've looked into that a little bit, isn't it? Do you want to bring in internal family systems here?
Yeah. So, well, I'll briefly mention. So, this is the work of Dick Schwartz, and he. I first came across it when I listened to. Rangan Chatterjee had Dick Schwartz on for an episode. I mean, this is going back a number of years, and I listened in and I thought, oh my goodness, this makes so much sense to me. Just his description, of course, and then he did a live kind of demo with Rangan, and it was really quite dramatic. And I thought, oh my goodness, this is kind of, yeah, it just made sense. And I suppose I'll just briefly explain. So Dick Schwartz was kind of his training was in family therapy, and what he found from some of his patients, that they were talking about parts as if there were kind of internal parts which were kind of part of them in some ways. And then he started then developing this, and so the different parts were exiles, which were your burden parts, which kind of had absorbed all your trauma or carrying these burdens often since childhood, and then there were these other parts, protector parts, which did everything that they could to keep these exiles under wraps. They didn't want them to kind of come to the surface because they didn't know what was going to happen. They'd be really worried. And the protectors were made up of managers and firefighters. Managers try to control the external world as much as it could to kind of avoid these exiles bubbling to the surface. And then because you can't control the external world completely, you then had your firefighters, which would come in, and when the exile was kind of bubbling to the surface, it would they would come in and douse the flame. So it would kind of be things like, maybe resort to kind of alcohol, sometimes even self-harm, but things like that, to kind of quite dramatic things. In order to kind of stop this exile kind of coming to the surface. So really fascinating kind of way of, I suppose, encapsulating what was going on internally. And also, like you were saying earlier, an opportunity, therefore, to kind of introduce different ways of therapy. So different therapeutic approaches.
Yeah, it's really interesting, isn't it? And it's a very neat package in a way, isn't it? It's like a metaphor, I guess, really, isn't it, for how your different styles of emotions play out in your mind and the symptoms that come from them, as we discussed. But I think what's really interesting is it leads to a way of addressing these things, isn't it? Giving people a way of conceptualizing it, and then allowing you to do that emotional work, I guess, isn't it? And seeing the value that has in helping you to cope with perhaps previous trauma, but also then the effect it has on calming down your symptoms. Be them unhelpful thoughts or physical symptoms that play out in your body. So it's got real promise, isn't it, as a doable technique? Again, I think.
Yeah, and again, with expert hands, you wouldn't be able to do this. I mean, they are IFS therapists. There's a long kind of robust kind of training program. So again, we're just talking about it here because we just want to raise people's awareness of and to maybe look into it a bit further. But certainly, if you want to be a practitioner, then there's a whole lot of stuff that you need to do in order to do that.
Yes.
But I think it's
Yeah.
really fascinating.
Yeah, no, absolutely, and I think it was particularly struck me because it was in Basil van der Kolk's book, and I think he was pushing the so what. So we've got this approach to recognizing the importance of trauma and working in trauma-informed ways, but actually there's a lot of things we can do, and I think that for me that is the most exciting bottom line of all of this, is that if we start to recognize these things, if we start to proactively diagnose them for what they are, rather than saying they're medically unexplained, sorry, nothing to do here, you're just going to have to live with it. We recognize them, we can start to treat them properly, and we can see people getting better. And that's just ultimately what we want to do, isn't it?
Yeah. Yeah, and again, the positive part from the kind of trauma is not, I think for some people has been, well, we can't do anything about it. It's almost like this traumatic thing has happened to you, and there's nothing we can do about it. Whereas I think this approach offers some hope for people
Yeah.
who've had trauma.
I
Yeah.
like that phraseology. I've heard it a lot. I heard it with a group of firemen the other day, actually, interestingly. And the fire chief was saying, yeah, we're moving away from post-traumatic stress disorder to post-traumatic stress injury. It's a set of experiences that happen to people that's created a reaction in the body. But just like any other injury, with the right treatment, we can help you recover. Some injuries, lifelong, life-changing, and it's difficult to recover. But actually, we always, when it's termed as an injury rather than disorder, it gives you hope that you can find the right treatment. It's just really exciting to me that for me, that's what the mind-body approach is doing, is opening new treatments.
Great. Wow. Goodness, that's been a great discsion. Who knew where we
Yeah,
were going to
who
go?
knew
So,
that was going to go?
yeah. So
Yeah.
is there anything more before we close? Ollie, is there anything more you want to share?
No, just good luck to people that are brave enough to take this on, I think. And I think, a bit of compassion to everybody, because, whenever you explore something new, you're going to get something wrong sometimes. We can't expect to get this right straight away. But I think being brave enough to open your mind and widen your scope of thinking, and be then also brave enough to say when you got things wrong as well. There'll be some things with this that we don't get right. But let's go forward bravely. Is that some kind of Star Trek term? I don't know. But, health coaching and beyond, we're taking it into the future. Go forward bravely.
Yeah, I think that's good. Yeah, let's be brave and let's be kind. Let's be kind and compassionate.
Brilliant. Great place to finish. And as always, if you've listened to the end to this far, thank you very much. And please do share your views. We have these chats because we hope it stimulates some thinking in you, and that, you'll want to share what you're thinking as well, and we can all learn together.